Very good afternoon. Thank you for joining us here at this afternoon session. I'm very happy and honored to moderate today's session as the co-chair of WEB, and even more happy to have Dr. Paula Moraga, an assistant professor at KAUST, to present to us about her very exciting work. So just want to give a quick introduction of Dr. Paula Moraga. Dr. Paula Moraga received her PhD degree in mathematics from the University of Valencia and her master's degree in biostatistics from Harvard University. Her research at KAUST focuses on the development of innovative statistical methods and computational tools for geospatial data analysis and health surveillance. And the impact of her work has directly informed strategic policy in reducing disease burden in several countries. For instance, identifying targets for intervention of diseases such as malaria in Africa, leptospirosis in Brazil, and cancer in Australia. And in yesterday's talk with Professor Gabriel Leong, we have learned about how tracking the movements, migration, and connectivity across individuals could explain the transmission of infectious diseases such as SARS-CoV-2. And in today's talk, Dr. Paula is going to further continue along that line, explain how traditional surveillance systems that rely on data gathered via periodic reports can lead to a considerable delay in terms of medical diagnosis and intervention measure implementation. And specifically, she's going to show with us how digital information such as the health-related social media posts and search engine query logs can drastically change that limitation. So without any further delay, I'm going to hand over the mic to Paula, and I hope we will all be very enjoying today's session as well. Thank you.
Thank you very much for the introduction. It's a pleasure to be here and be able to speak about my research. And it's also great to see so many great talks about connectivity in different fields. So, today, I'm going to talk about how open data and collaborative analytical tools can help with decision-making in public health. I work on the development of statistical methods and computational tools for geospatial data analysis and health surveillance. I have developed methods to understand the spatial and spatiotemporal patterns of diseases such as malaria in Africa, leptospirosis in Brazil, and cancer in Australia. And I've also developed a number of statistical packages for disease mapping, detection of clusters, and risk assessment of travel-related spread of disease. So in today's talk, I'm going to talk about health surveillance and its relationship with connectivity. And I'm going also to talk about the importance of open and reliable data and analytical tools, as well as communication and dissemination in public health. I work in disease surveillance, in health surveillance, and human health is interconnected with animal health and with the environment. There are many diseases that spread from animals to humans, for example, rabies, avian influenza, West Nile virus, leptospirosis, and even coronavirus is thought to be originated by bats. There are also vector-borne diseases that are transmitted by mosquitoes or ticks, such as dengue, malaria, yellow fever. And human activities and development are causing the emergence of new infectious diseases. For example, deforestation is putting wildlife in contact with humans. Climate change and increased temperatures are causing that mosquitoes expand to new areas, and diseases that usually occur in tropical and subtropical regions of the world are now occurring in new areas. And also global travel makes that diseases spread beyond national borders. People living in an infectious location can get infected, and when they go abroad, they may infect people abroad. And also people that come to the infectious location for holidays, for example, can get infected, and when they return to their home countries, they can infect people in their home countries. So it's very important to acknowledge this connectivity between people, animals, and their shared environment, and to work together in order to solve global health challenges. Now I'm going to give you two examples of projects where I collaborated with multidisciplinary teams of scientists to map and to identify risk factors of tropical diseases. The first project is about lymphatic filariasis in sub-Saharan Africa, and the second project is about leptospirosis in Brazil. Lymphatic filariasis is a disease caused by microscopic worms and transmitted by mosquitoes. So when the mosquitoes bite the person, the worms go to the lymphatic system, and there they cause blockages that cause swelling of the arms and the legs, and also thick and hard skin. And this is a disease also called elephantiasis. People with lymphatic filariasis suffer a lot. This is a very painful disease. People with this disease are rejected by those in their communities, and this leads to a lot of suffering and to poverty. Lymphatic filariasis affects tropical and subtropical regions of the world, such as South Africa, Sub-Saharan Africa, Asia, the Pacific, and also part of the Caribbean and South America. The main strategy against lymphatic filariasis is mass drug administration, which is recommended to entire populations in regions where prevalence exceeds 1% annually for at least 5 years. So ideally, we would give the resources to everyone that needs them, but in reality, resources are limited. So we need to decide which are the areas most in need. In this study, we wanted to predict prevalence of lymphatic filariasis in sub-Saharan Africa. And we had this data, so we had 3,000 surveys taken at specific locations in sub-Saharan Africa. So at each of these locations, there was a survey that recruited a number of people. Some of the people were tested positive for the disease, and other people tested negative for the disease. And the prevalence at each of the locations is the number of positive people divided the number of people in the sample. So here we can see the prevalence values taken at particular locations in sub-Saharan Africa. Here you can see that there are some locations with very low prevalence, other locations with very high prevalence, and this gives us an idea of the burden of the disease. But we don't know anything about the prevalence in areas that were not sampled. So what we want to do is to go from this map in the left to this map in the right that shows a spatially continuous surface of the prevalence. So here in this map, we can see how the disease risk varies in a continuous surface. And we can, and this is good for decision making to allocate areas with higher and lower prevalence and to allocate resources. So to compute that map, we used a statistical model. So for those of you that know statistics or probability models, this is, so at location XI, we have a survey with NI people, and out of NI people, YI are positive. So this is a binomial distribution. The number of people that tested positive follows a binomial distribution with parameters M, the number of people in the survey, and the prevalence, so the probability of having a disease. And then the logit of the prevalence is expressed as a sum of covariates plus random effects. In the covariates, we include characteristics that we know that affect lymphatic filariasis transmission, such as precipitation, vegetation, elevation, land cover, population density. All of these affect the risk, because we know that this is a vector-borne disease. In addition to these characteristics, there are other factors that we cannot measure or we don't know about, and the variability of these factors will be modeled using random effects. And here we put two random effects. One of them is a spatial, and we use a spatial random effect to recognize that it's possible that two locations that are close to each other have similar risk. And we also have an unstructured random effect to recognize that although two locations may be close to each other, they may have different risk. So we fit the model, and this is what we get. So we get a map that shows the predicted prevalence in sub-Saharan Africa. We see that the risk is higher in the east coast of Africa, east coast of Madagascar, and also in pockets in the west. And we see that it's lower in Ethiopia and in the center. In addition to this map, we also calculated maps showing the lower and upper limits of 95% credible intervals that show the uncertainty of these predictions. And these maps can help surveillance activities by identifying areas that require enhanced interventions and allocate resources. And they're also useful for setting a benchmark for evaluating the impact of interventions. In the second study, I'm going to show the project about leptospirosis in Brazil. Leptospirosis is a disease that is transmitted by the urine of the rats or an environment that is contaminated by the urine of the rats. People with this disease have fever, headache, and also more severe symptoms such as pulmonary hemorrhage syndrome. Leptospirosis is an urban health problem due to the rapid and disorganized expansion of urban centers that creates ecological conditions for rat-borne transmission, and it affects populations such as farmers and residents of urban slums in the tropics. So in this study, we assessed leptospirosis in Pau de Lima. And Pau de Lima is an urban slum community in Salvador de Bahia in Brazil with a high annual incidence of leptospirosis. So here you can see an aerial photograph. The Pau de Lima has 4 valleys. In the bottom part of the valley, there is a lot of vegetation and the sanitation conditions are very bad. And in the upper part of the valley, houses are close to a main road and the sanitation conditions are much better. Here you can see a few photographs. We can see that households are at different elevations. There is a lot of vegetation, accumulated trash, open sewers, and rats can be seen very easily. And moreover, people carry out activities that are high-risk activities, such as being in contact with mud and water that could be contaminated. So the objective of this study was to understand the spatial and spatiotemporal patterns of leptospirosis and identify targets for intervention in Paula, Lima. We recruited 2,003 subjects and followed them for a 4-year period. And each year, we administer questionnaires and GIS mapping to determine socio-behavioral and environmental risk factors. And then, using this information, we fitted a spatiotemporal model. So here, Yij is equal to 1 if person I at time j has the disease and 0 otherwise. And Yij, conditional on the prevalence, follows a Bernoulli distribution with parameter the prevalence. And then, as before, we model the logit of the prevalence as a sum of covariates plus random effects. In the covariates, we put information that we know may affect disease transmission, and the random effects model variability that cannot be explained by the covariates. So there will be other factors that we don't know about or we cannot measure, and all of this variability will be included in these random effect parts of the model. And we use a spatiotemporal random effect to model that. These are the factors we selected as a candidates for covariates in our model. They are grouped in 8 categories. We have demographic and social status factors such as gender, age, being literate. We have health factors such as diagnosed with dengue since last visit or vaccinated against yellow fever. Occupational exposures such as working in Paula, Lima or working in garbage removal. Household environment such as elevation of the household or distance to wet sewer or trash. Household and work behavior such as contact with flood water, sewer water, mud or trash near house or near job. And household and work reservoirs such as observing rats or the number of rats seen near house or near job. So we had all of these factors, and then we follow a statistical approach to select some of these factors to be in the model. And this is what we did. So we had 8 groups, sorry. Within each of the 8 groups, we fitted a model using all the variables in the group. And then we followed a backward elimination approach to select the most important variables. Then we merged all the variables that were selected in each of the groups and did the same. We followed again the backward elimination approach to select the most important variables. And this is what we got. So we observed that the risk of leptospirosis was higher in GR4 compared to GR1 and was lower in GR3 compared to GR1. And we saw that risk factors were being male, being illiterate, observing rats near home, and contact with mud near home. In addition, we also saw that a nonlinear effect of age. So the risk of leptospirosis increased with age until age 20, and then it is more or less constant. And this makes sense because young people and children have more risk activities, such as being outside in contact with mud or water that could be contaminated. These maps show the areas with the highest in red and lowest in blue odds of infection. We see that the risk pattern is consistent over time. We see that the areas with the highest odds of infection are located in the bottom parts of the valley where the sanitation conditions are worse and there is more vegetation and trash accumulated. And the areas with the lowest odds of infection are located in the upper parts of the valleys that are close to the main road and have better conditions. In addition to this, we also examined the residuals because we wanted to identify locations where the risk was higher or lower than predicted by the risk factors. This location, for example, is a high-risk region in which the risk is consistent with prediction. So the residual is 0. And here we can see a lot of vegetation, accumulated trash, open sewers, and rats can be seen very easily. This is a location with high positive residual. So the risk is higher than predicted by the risk factors. And this is because there is poor household construction and there is flood risk due to poor infrastructure. And these are locations with high negative residual. So the risk is lower than predicted by the risk factors. And here you can see that these are locations with open sewers that a priori this will increase the risk, but these specific sewers have barriers to stop overflow, so the risk is decreased. So we have seen that with these two examples that to solve global problems, it's important to collaborate with a multidisciplinary teams of scientists. So we need people in the project that know about statistics, but also epidemiology, entomology. We need public health experts. And we have also seen that to solve global problems and to answer questions, we need data. But we don't need just any data. We need reliable, relevant, timely, and detailed data. For example, we need demographic data because we need to know how different groups of the population are doing. So we need to know who is at risk of diseases. And we can get this information from population registers and from censuses that provide information on fertility, mortality, and migration. But it's also very important to get demographic data that is disaggregated by gender, by age, by geographic location, and other characteristics, because this is essential for addressing the needs of all groups, including the most vulnerable groups, which are often overlooked when populations are considered as a whole. We also need climate and environmental data. So we have seen that there are diseases that are affected by factors such as temperature, rainfall, humidity, elevation. So it's important to use this information for including in the model and to be able to quantify the effect of these factors on the disease risk. And we can get this type of information, for example, from satellites and also from monitoring stations that measure these characteristics on the ground. And we also need geographic data for planning. Like, for example, if we want to distribute medicines or to plan vaccination strategies, we need to know where the people live, where are the houses, what are the distances from the houses to health facilities, and so on. So for example, this is a map of London, and this is obtained from Google Maps. So here you can see a very detailed map with all the buildings, big roads, small roads, health facilities, hospitals, metro stations, schools. So we have a very detailed map that is very useful for planning resources. But we need to be aware that, unfortunately, this is not the same in all parts of the world. Like, for example, this is a map also obtained from Google Maps that shows a village in Mongolia. And here we also see, we only see 4 streets and 2 points of interest, and that's it. So as you can imagine, this is not good for planning resources. So we need to be aware of this situation, and we need to improve the availability and quality of the data worldwide to be able to reach all populations. And we have seen that data is important in public health, but data is also key for monitoring and achieving the global sustainable development goals set by the United Nations. For example, we need data to see if we are in the right track to eliminate poverty, reducing inequalities, and improving the environment. Okay, so it's clear that we need data, but now the question is where to find this data. So we have created a website that is called our Spatial Data GitHub.io. And this is a website that collects, it's a collection of data sources and tutorials to access and manipulate and visualize spatial data using the statistical software R. In this website, you can find tutorials and other information about how to access administrative boundaries from geo boundaries. We can also get population, disaggregated population data from WorldPop. We can also get climate and weather data from the WorldClim dataset. We can also access satellite images and geospatial datasets using Google Earth Engine. And we can also get, for example, OpenStreetMap data. So we have seen that to solve global problems, we need data, and we have seen that we have access to a vast amount of data from different sources. And now the question is, okay, so how can we analyze these data sets that come from different sources that are given at different spatial and spatiotemporal portions of the data into account? So we need analytical tools to integrate complex data to obtain valid inferences. And I'm going to give you a few examples of the importance of analytical tools when we model this type of data. For example, we may be interested in mapping air pollution. Specifically, we may be interested in mapping fine particulate matter, or PM2.5. So these are very tiny particles that are less than 2.5 micrometers in diameter. And these particles come from fires, from motor vehicles, from industries, And these are so tiny that they can get deep into the lungs and cause very serious health conditions. So it's important to monitor particulate matter levels and take action if these levels exceed the recommended levels. So we can get data of particulate matter from satellites. Here, for example, we have a map of Europe, and we have a raster grid that shows average particulate matter values. So here is, we have a grid. So in each of the cells of the grid, we have a value, a single value for air pollution levels. We also have access to data that are taken with monitoring stations. So these are ground measurements. And here again, we see a map of Europe, and each of the points represent air pollution measurements that were taken using monitoring stations. So on one hand, we have air pollution levels taken at point data. This is very precise. This gives us air pollution at a specific sites, at a specific coordinates. But again, we don't know what's the air pollution levels where we don't have monitoring stations. But we can complement this data with these raster grids that show air pollution in areas. But again, these areas have a resolution that don't allow us to see how air pollution varies within these raster cells. So the question here is, how can we combine these two data sources? So how can we predict air pollution using point level data from monitoring stations and area level data from satellites? And we need statistical techniques in order to do that. Another example is in disease mapping. We have seen that disease maps are very important to understand the spatial and spatiotemporal patterns of diseases and identifying risk factors, and also to allocate resources. So here, for example, we have a map of malaria prevalence in Mozambique. And we have that the prevalence is given in regions, like in areas. So here we can see that the prevalence is higher in the north than in the south. This gives us an idea of the burden of the disease, but again, this is not very useful for decision makers, because if they need to allocate resources, they need to know what are the locations with high and low prevalence. And here in a given region, we only have one value. We are not able to see how disease risk varies within the area. So the thing that we need to do is to have methods that are able to disaggregate area level data and compute high resolution estimates of disease risk, which is better for decision makers, because here, for example, in a given area, we can identify locations with high risk and low risk, and this is much better for decision making. Another example is when we want to quantify risk factors. Like if we want to understand what is the relationship between a response variable and an explanatory variable, and these two variables are given at different spatial scales. For example, we may have that we are interested in studying the relationship between lung cancer that is given at county level and smoking that is given at the state level. So how can we match these two data sets to find a relationship? So this is a problem that it's also very common, and we need tools to solve it. Another problem is when we want to detect outbreaks. And for doing that, we have disease surveillance systems that help us to detect epidemics and to design control strategies. But traditional surveillance systems have a limitation, and is that information is delayed. From the time that the person gets sick to the time that the person decides to go to the doctor, goes to the doctor, have the laboratory tests, and that information is in the system, it may take a few weeks. So this information is not useful for taking action in real time. Nowadays, we have access to other types of information. For example, we can use digital data, such as social media posts, where people chat about how they feel. For example, they can say, I have flu, I don't feel well, I have cough, and so on. And we can mine this information to understand how people are feeling. We can also access Google search data, where people search treatments for their conditions. And this information is not produced for epidemiological research, but we can use it to understand disease activity levels in real time. Also, we can use demographic and environmental risk factors to help us predict epidemics in real time. So there are many diseases that are affected by climate and environment. For example, diseases such as dengue, malaria, they are affected by rainfall, temperature, and we can use this information to anticipate global health threats. And the question is, okay, we know that all of these data sources are useful for prediction, official disease data from traditional surveillance systems, real-time digital data from social media and Google searches, and also demographic and environmental risk factors. But again, these data sources come from different sources, have different limitations, and come at different spatial and spatio-temporal resolutions. For example, if we focus on digital data and we want to use this information to predict outbreaks in real time, we need to be aware that not everybody uses social media platforms. Only, well, mostly young people and more educated people do. And also internet penetration is not the same in all places. If we consider demographic and environmental risk factors, we have that some areas, some countries have very good coverage, but there are other regions like in low and middle income countries where we don't have disaggregated level data to be able to do these predictions. So it's important to develop new statistical methods that are able to integrate data from multiple sources and at different spatial and spatiotemporal resolutions, taking into account all the biases and uncertainties to produce local predictions of disease activity in real time. And we've seen that data is important, analytical tools is important, and it's also important to work with others and to share our data and analytical tools with others. For example, imagine that I'm working in a project and I developed a solution for a particular problem. I solved my problem, and then I produced some results, and I share and I publish a paper with the results. But I keep the code for me, the analytical code. So this is not good for science. And this is for two reasons. First, it doesn't make sense that I share the paper and I keep the code for me, because if someone else is working in the same problem, they read my paper and they say, okay, I'm going to do the same. So they will need to again write the code that I already wrote. So it doesn't make sense that he needs or she needs to replicate work that I already did. It's much better that I share the code with others and they can reproduce my results and they can advance with their research much faster. And also it's a way to validate my research, because if other people are using my code, they can identify, they can check whether there are mistakes, and they can also identify areas where my work needs to improve. It's a way also to collaborate and to improve the work. So sharing data and code enables reproducibility, reliability, and to advance science faster. And there are organizations that do exactly this. One of them is rOpenSci. rOpenSci is an initiative with the mission to foster a culture that values open and reproducible research using shared data and reusable software. rOpenSci develops a lot of different packages that help researchers in their work and make science more impactful. They have packages for data access, data extraction, data visualization, databases, and they also build packages for statistics, such as Bayesian methods, machine learning, regression, networks, exploratory data analysis, and so on. And what they do is to use an open peer review system in GitHub that ensure quality and robustness of the software. So, and this is how it works. So when someone has a package, the author of the package submits the package in GitHub, and then there are two external reviewers that make sure that the package adheres to the best practices and standards. So they review the package and they make sure that the functions are reusable instead of repeating code, and that all the code is documented. Then the author and the external reviewers maintain an ongoing conversation. This is an open conversation. Everyone can contribute to this conversation as well, and the identities of the author and the reviewers are open as well, until acceptance of the package. And this conversation is open and collaborative. So this enables to build a community for shared learning, collaboration, and reproducible science. Another organization that publish open and reproducible packages is RECON. RECON stands for the R Epidemics Consortium, and is an organization that gathers experts in data science, modeling, public health, and software development to create the next generation of analytical tools for disease outbreak response. And they have a lot of packages to access, manipulate, model, and visualize epidemics data. One of their packages is EpiFlows. And EpiFlows is a package to assess a risk for risk assessment of travel-related spread of disease. So as I mentioned at the beginning of the talk, diseases can spread beyond national borders. People living in an infectious location can go abroad and infect people abroad. And also people that come to the infectious location can get infected. And when they return to their home countries, they can infect people in their home countries. So this package implements a mathematical model that predicts the number of cases that could be spread to other locations from an infectious location together with uncertainty measures. And what it does is to calculate the exportations and importations of cases using information about the number of infectious cases, population flows, lengths of stay, and incubation and infectious period distributions of the disease. Another package that is open is a Spatial AP app. And this is a package that has an interactive web application for disease risk estimation, for detecting clusters, and for interactive visualization. So here the user needs to upload the map and the data, and then by clicking some buttons, they can obtain disease risk estimates, they can detect clusters, and they can also visualize their results in an interactive way using interactive maps, time trend plots, and tables. And they also have the option to generate reports. And again, this is a package that is open and is given for everyone that needs to use it. And also we need data, we need analytical tools, and we also need effective communication and proper and timely dissemination for the development and implementation of population policies. So one way to do this is to use interactive visualizations that allow us to explore data in an interactive and approachable way. For example, using maps, time trends, tables, and other visualizations. So here, for example, we have two HTML widgets. One of them shows a time trend plot where the user can modify the x-axis. They can also hover the mouse and see the values for the trends. We can also compute interactive tables, and these show the results in an interactive way. So here we can search words. We can also sort the columns. And these visualizations, these particular visualizations are created with the statistical software R. They are very easy to implement, and they are very useful for communicating. They are very useful for communicating results. We can also create maps using Leaflet. The Leaflet is a JavaScript library for interactive mapping. And here we can overlay maps of health data, risk factors, political boundaries, and other geospatial information that can be useful to put data into context. And again, the user can interact with this visualization. They can zoom in, zoom out, they can move in the map, and they can visualize the results in a faster and in a more approachable way. And of course, we can also put all the visualizations together in a dashboard or in a web application that the user can interact with. For example, this application shows air pollution globally. And here the user can filter the countries they want to see, and they have a map, an interactive table, and also a histogram with the values that change when the user filters the values. And these type of dashboards are very useful and very important to identify information for specific regions, to understand how disease patterns change over time, to compare risks between populations, to measure inequalities, and to anticipate health threats for better planning and response. So to conclude, I hope I've shown to you that open and reliable data and analytical tools, as well as collaborative research, are crucial for solving global health challenges and for achieving global sustainable development and leaving no one behind. These are some references about my work in statistics, statistical software and applications in health and the environment. And if you are interested in learning how to fit this type of models or how to work with this type of data, you can also take a look at this book, Just Spatial Health Data, Modeling and Visualization with R, ILA, and Shiny. This book is published by CRC, but it's also freely available online, and you can find it in my website. And this covers how to manipulate, visualize spatial data, how to create maps using R, how to feed spatial and spatiotemporal models, and how to create interactive visualizations, dashboards, and web applications to communicate results to collaborators and policymakers. In addition, the book focuses on health data, but the approaches covered are also useful in any discipline that use spatial data. And that's it. Thank you very much for your attention.
Thank you very much, Paula. And I would like to maybe start with the Q&A. We have about 10 minutes to go for the Q&A. And I guess I've already received some questions that are asked on the event podium. So I'm just going to maybe go through them. So the first question, I guess, is more from the general perspective. And so just now in one of your slides, you mentioned that there's a need for multidisciplinary scientists to come and work together. But I guess often the training language barrier is quite difficult to break through, right? I mean, like people from having statistics background versus people from, let's say, epidemiology background, they may be talking very different language. I guess that's what the question is about. So how, based on your past experience, do you resolve that? Do you have any like tips or approach to resolve that language barrier and connect with people of different training background?
Yes, so this is a very, very good question, and it's a very common problem that appears when multidisciplinary teams work together. But the thing is that we need to learn from each other. So, and I think you can learn these skills and how to communicate with others with experience. So at the beginning, in the first project, maybe if you are trained as a mathematician, you are used to work with a specific language, and it's difficult for you to communicate. But there are always more senior people with more experience that will help you. And I think that maybe the first project is difficult, but then you will learn with experience and collaborating with more people that can help you.
So from your experience, how diverse was your team like?
Well, very diverse. Like, for example, my projects are related to analyzing diseases that are affected by climate and the environment. There are vector-borne diseases. So there are a group of statisticians and mathematicians that know how to wrangle with the data, how to feed the statistics and mathematical models. We also need epidemiologists, people that know about the disease, because these are the people that are going to help you with the model, because I can I can build a very sophisticated model with the covariates that obtained with my statistical procedure, but the epidemiologist is the one that is going to say, I think this covariate is going to be important because this is our risk factors, we already know that. I think this is not going to be very important. And by working with this epidemiologist, you can build a model that makes sense, not only from the statistics point of view, but also from the point of view of our epidemiologists. We also need people that work in the field. So these are the people that are going to go to talk with individuals in the villages. Some of them maybe need to talk the local language. Not everybody, not all the countries we work with talk English. We need, for example, entomologists that know about mosquitoes and so on. So it's very diverse. And also we need people that is involved in policymakers and are able to communicate our results to these people that are the ones that are going to take the decisions.
Indeed, in order to solve grand challenges like what you are working on, it's always very, very important to make sure that multidisciplinary fields come together, because let's say basically if people are just in terms of epidemiologies or just training in statistics, they themselves alone sometimes are just too focused on one area and may not be able to see the big picture. And I think nowadays when it comes to solving grand challenges, it's very important that we really look at it from a macro perspective and provide our individual expertise to work synergistically together to solve all this. And therefore, having that person who understands and appreciates and open enough to, to accept ideas or information from the other fields are definitely very, very important assets nowadays in working science. So I think that's definitely a very good start to the question, especially as it relates to the theme connectivity. So perhaps the second question is more in terms of the later part of your presentation when we're talking about, for instance, gathering social media data. And I guess, with what's going on in the previous administration in the US, a lot of people, when they talk about social media, they're also thinking about fake news or fake posts or even automated bots that are just randomly posting stuff which may not even come from a real individual. So besides having privacy concerns, are there also any accuracy concerns related to gathering data from social media posts in order to predict, for instance, infectious diseases outbreak or certain elements that may be affected by the true content of social media posts?
Yes, so I understand that many people have these fears. They are concerned because there are some companies that want to get your personal information, but not for good, but for influencing opinions or for having profit. But there are governments and there are institutions that establish regulations to protect the individuals, and this is something that is very serious, and they are there to protect the population. And we as researchers, where we want to use this type of data to monitor diseases, for example, we always use anonymized data. So, for example, I can get this information, but then I can know the number of people that has fever, for example, in an area. I don't have the exact coordinates, the exact location. So so I use data that are anonymized. But in the case that I need more precision and I need to know the exact location and I need to know the age or the gender, and this is information that I can use to identify the person, is not that we as researchers can get the data and that's it. We need to ask permission to these bodies in the government that has these regulations, and they will ask several questions. So they will ask, why do you want this data? What is the purpose of this data? What are you going to do with this data? Why do you need so precise information? It's not enough to have anonymized data and that's it. And you need to justify why you need precise data. And then they will ask you, okay, with the results. If you publish your results, are you going to identify someone or not? What are you going to do with the data? Is the data going to be destroyed? If it's not going to be destroyed after the research, what are you going to do? Are you going to have it for a few months? So there are many questions that we need to go through, and these people that know a lot about ethics, about privacy, they will ensure that population is protected and the personal information that we can get is protected and is only used for the research purpose.
So it sounds like privacy, perhaps concerns related to privacy or identify confidential information of an individual is not that much of a big concern. But what about from the research perspective, how accurate is it to get data from social media posts? Because there may be instances where people are just randomly posting stuff for attention seeking or just because one person is bored or something. So how do you eliminate the bias or the inaccuracy that may be related to gathering data from those, social media posts?
Yeah. So, for example, if we want to know people that is sick and has fever, for example, people can say, I have fever, I don't feel well, I cannot go to work. Or other people can use the word fever in other contexts, like having fever for a singer. So you need to differentiate the context. Mm-hmm. And ideally, we would use machine learning algorithms that work with big data and are able to separate out tweets or social media posts that relate to people with disease to other people that use these words in other contexts. And of course, these machine learning methods or statistics methods are not perfect, so there will be an error. But most of the times, we will use, we will be happy with these errors because they will not affect much the results, or we will use models that are more sophisticated that are able to deal with this type of biases in the model.
It's definitely a very exciting field that you're working on. And hopefully we can maybe meet offline to discuss a little bit more about the related work. So we are running out of time, and thank you very much, Paula, and thank you to all participants who have attended today's presentation. I hope you walk away with more new exciting insights into what Paula is working on. Thank you very much, Paula.
Thank you. Thank you for having me. It's been a pleasure.
Bye.